Get started. Welcome, everyone. My name is Abby Hunt. I'm the Executive Director at Healthcare Education and Training. If you're new to us, our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And we do that across the Midwest, primarily as our focus area. I'm really excited to welcome you to this webinar. It's the first in our series that we're really expanding our work to focus on people who are over 40 and their sexual and reproductive health. So we're calling this series Menopause Mondays, a different kind of monthly. And our first that you're joining is we are going to talk all about navigating menopause and how we can find the right healthcare provider. The next 3 sessions coming up, we hope you'll join us. They're going to be about hot flashes. We're going to talk about sexual and reproductive health, specifically in menopause. And we're going to talk about the invisibility of women as they age. I'm pretty excited to share that we have about 167 people registered today from about 7 states. So before we get into it, we're going to do a little housekeeping. We want to make sure that this is accessible for everyone. You should see a button at the bottom if you'd like to have enable subtitles. Click on the live transcript icon, then click show subtitle, and you can look at your accessibility settings if you need further help. To ask a question, please click the Q&A icon. It says will be answered at the end of presentation, but we're likely going to break after the presentation before we do some fun interactive role plays to take some Q&As for the first round. Please connect with us if you haven't. You can find us on Facebook, Instagram, and Twitter at hct.org, our website, hct.org, and learn.hct.org is where we store all of our virtual training options, hold webinars, etc. So please check that out and find what else we have to offer for you. Please help us be better. We'll send you a link to complete the evaluation after this webinar. We love your feedback. We love all kinds of feedback and we appreciate it all. So feel free to be pointed and specific. We do use this and integrate it into our future work. You can also visit our website to see archived presentations and upcoming events at hct.org. And this email below for technical difficulties is being monitored. So please feel free to email if you're having technical difficulties at any point. If you are a nurse and you would like to receive nursing contact hours, you must do the following: attend the entire webinar, return the completed participant evaluation and protest, and complete and send the email to Kelly at the email below. Here are our disclosures. I will pause, let you read them. I'm not going to read them to you. And now I am very pleased to introduce you to Janet Carpenter. Dr. Carpenter is a menopause scientist whose research has improved the understanding of hot flashes and palpitations. She's developed new ways to study hot flashes and provided clear evidence on how to manage them. Some of her many honors include USA Today Women of the Century for Indiana, Indiana Women of Achievement, Council for the Advancement of Nursing, and Science Outstanding Nurse Scientist, Fellow of the American Academy of Nursing, and Sigma International Nurse Researcher Hall of Fame. Currently, we are lucky to have her here in Indianapolis, where HCT is based, as the interim dean and a distinguished professor and Audrey Easel Endowed Chair of Innovation at the Indiana University School of Nursing, which has campuses in Bloomington, Fort Wayne, and Indianapolis. So at this point, I would let you take it over, Dr. Carpenter.
Thank you so much, Abby. I really appreciate the opportunity to do this webinar today. I was so excited when you reached out. So as Abby said, we're going to have sort of a 2-part presentation. We're going to talk a bit about menopause and then go into some role plays with provider-patient interactions. Next slide. Next slide. So Abby gave me a great introduction. I'm a nurse. I started my work in women with breast cancer, actually, who were having a pretty severe menopause because of the cancer treatments that we give them. And since that, those early years, I've expanded my work more into women without breast cancer, healthy women, everyday women in the community. So I know a little bit about some special populations and also the average woman. So welcome, bienvenue, and bienvenidos. All right. So we're going to cover 4 parts here. And the first three will be in part of the presentation. And then after those first three, we'll break for some questions. And then we'll do some role plays and have some discussion about those role plays. So we're going to talk about understanding menopause. Oh, can you go back, Abby? Sorry. Understanding menopause, giving you some tips to find the right healthcare provider and ways that you can prepare for your appointment with a provider. So you're getting a nurse consultation today. All right, next slide. And you can go ahead. So this is some art that I created, digital art, that shows you the menopause transition as a pathway, because I think it is a pathway in our lives. And we go from pre-menopause, where we're having periods, into perimenopause, where our periods slow down, into the post-menopause, when we don't have any menstrual periods. You see the green leaves indicating the premenopause is a very fertile time. The perimenopause can be a little rocky, which is what those brown things are by the side. And then we continue on with a fertile period in our lives, just in a different way. We're not creating children, we might be creating other things in our older age. And that 1 year no periods time with the balloons is your menopause day. And so we're going to talk about that as well. Okay, well, go ahead. So premenopause means before. Pre means before your periods stop. You're still having periods. We talk about these as childbearing or child rearing years. Usually begins around age 12 with your first menstrual period. Up to around age 42, it can be older for some women. It can be earlier for some women. The perimenopause, peri means near. So this is near the time when your periods stop. This can be anywhere from age 42 to 55 on average. Although again, women can be early or late with this perimenopause period. Next slide. So the menopause day marks 12 months from the day of your last period. So if you feel like your periods are irregular, like you might be in perimenopause, it's a really great time to begin tracking your cycles again so that you can keep track and count how many months it's been since your last period. My very best friend in Michigan, we've been friends since we were 11, before we even started having periods. At the age of 56, went 9 months without her period, and then boom, had another period and had to start her clock all over again. So she was 57 actually by the time she hit postmenopause, which is a little later than normal. So that's the menopause day. And next slide. So postmenopause, post means after. So this is after you've finished your menstrual periods. So this whole rest of your life, from that time when you have your last menstrual period, you've gone 12 months without a period, that starts postmenopause, and you're in that time of life for the rest of your life, postmenopause. We talk about a median age, which is half of the women go through postmenopausal around age 51, before age 51, and about half of women reach postmenopause after age 51. So you'll often hear the age of 51 as the time when you start being postmenopausal. But as I said, there's some variation around there, around those ages. I think I'm kind of a geek, right? I'm a scientist, so I love to know weird facts. And I was really curious about who else has menopause. Like, does your cat or dog go through menopause if they're not fixed? And the only mammals on Earth that go through menopause are human women and some whale species. So your dog or cat doesn't go through menopause. And there's 4 different kinds of whales that go through menopause. And scientists think this is because when they watch whale colonies, the older whales are grandmothering the younger whales and the young females. And so they think this phase of life where you're not able to have children is actually beneficial in a societal kind of a way. So I think that's interesting. Okay. So the funny thing about the menopause transition, it can be premature, which is before age 40. I'm one of those folks that had a premature menopause. It can also be early, which is like between the ages of 41 and 45, or it can be late, like my friend in Michigan, which is age 55 or later. The menopause transition can also be natural or induced. So natural means your periods have stopped on their own. Nothing's causing them to stop. Or they can be induced, like my women that I used to study with breast cancer. The chemotherapy drugs change the way the ovaries work, and they cause an induced menopause, which often sometimes is an early menopause as well. Drugs like chemotherapy drugs or other drugs, or surgery, of course. So if you've had your ovaries, the uterus removed, you can be in an induced menopause. So in my case, I had a premature induced menopause. I required surgery for some gynecologic complications related to endometriosis at age 35. So I became postmenopausal at age 35. So premature induced in my case. And then the other way that the menopause transition can happen is caused by a medical condition that's called primary ovarian insufficiency. And this is sort of characterized by really irregular cycles, reduced fertility, so difficulty getting pregnant. And this menopause in these women usually happen before age 40. If you've had a hysterectomy, but you have your ovaries are continuing to function like they would if you still had a uterus. So you're just not having your periods. So it's a little bit harder to track menopause transition in a woman who has her ovaries but just doesn't have a uterus. And we will often do laboratory tests to look at hormone levels to try and figure out where a woman is in the menopause transition in that case. Okay, next slide. This is a graph of some hormonal changes in menopause, and the hormone levels go from 0 up to 120. And the lines that you see that are high on the left are E2 or estradiol, which is a type of estrogen. And so you see these levels around 50 to 70, and then they're dropping down to 20s. Sometimes they can drop even below 10. When we do laboratory tests on women who are postmenopausal, their estrogen levels are often non-detectable. So we can't even see them, they're so low. Then the other change that happens in menopause is the thing that starts low on the left is something called FSH, or follicle stimulating hormone. And this is what, when it's low, it works with your ovaries. Your ovaries are working well, you've got, you're ovulating, and when it gets really high, it means that the ovaries are sort of losing their function. And so you see your estradiol drops low and your FSH goes high. In the middle there, that 0 is your menopause day. So that would be the day of your last period, within that first year of your last period. And then the minus are years leading up to your menopause day. So that's really maybe pre to perimenopause. And then after the 0, the 2, 4, 6, 8 are your postmenopause years. And you can see after that sort of rocky time around the last menstrual period where the hormones are really fluctuating a lot, that they sort of level out. Your FSH levels stay high, your estradiol levels stay low. And this is a graph that the Menopause Society provides for educational purposes. Okay, next one. These are some common menopause symptoms. There is a lot of them. I put vasomotor symptoms, hot flashes, night sweats right there in the middle because they are actually the most common symptom. They affect about 3 out of 4 women. Some women have hot flashes during the day and night sweats at night. And some women just feel like they have the night sweats at night or hot flashes during the day. That can really vary. Some other common symptoms are difficulty falling or staying asleep. That also affects about 3 out of 4 women. We talk about that as insomnia, difficulty establishing sleep, difficulty maintaining sleep. There's lots of different names for that. But basically, you have a hard time falling asleep or you have a hard time staying asleep. This hard time staying asleep includes waking up during the night as well as waking up too early in the morning. Heart palpitations, we're finding, are affecting about 50% of women. So about half of women have some heart palpitations during the menopause transition. Mood and cognitive changes can be fairly common. I think these are similar to changes that women have maybe around their periods or even during pregnancy, right? Where it's not, it can be a full-on depression or anxiety disorder, but it's often like just a crankiness or a lack of patience with things. Right? Like you're just irritated. You just feel sort of irritated. I think that can be fairly common. About 1 in 3 women report those mood changes. People can have changes in their hair, skin, and nails, primarily feeling like there's a drying out of those things. And, you want to condition and lotion and like you can't get enough of that. Muscle and joint pains, as well as migraines, affect about maybe 1 or 2 out of 5 women. So they're a little less common, but they can be problematic at menopause. And then vaginal dryness, loss of interest in sexual relations. We call it lack of libido, right? And sometimes women can have painful intercourse because of that vaginal dryness. And there are some lubricants that can be used to alleviate that symptom. So those are some of the common menopausal symptoms that you'll see. And women often have some combination of these, right? It's not just one, unfortunately, they sort of go together. Because what happens is you might start having vasomotor symptoms during the day, then you notice they're waking you up at night. Your sleep is not great to begin with at menopause with the hormone changes. And then the hot flashes sort of add to those sleep difficulties, which makes you gosh darn cranky during the day, right? And so that, you can have like a cascade effect of some of these symptoms or a clustering where they just all hit together as well. About 1 in 4 women don't have any symptoms at all during menopause. And scientists are trying to figure out why that is. And it seems to actually not be the normal case. It seems like those women may have some genetic differences than the rest of the population of women who do have symptoms. Next slide, Abby. When I think of symptoms and trying to get treatment for symptoms and the impact on my life, I always think of this sort of seesaw situation, because how I feel about my symptoms might depend on the type of symptoms I'm having, the number or frequency, which is like how many I'm having. In one of my studies, we had a patient who had 50 hot flashes, 50 hot flashes in a 24-hour period of time. So that's just miserable, right? That's more than 2 an hour all day, all night long. Or the duration of symptoms. Some of the women might have, heart palpitations for hours at a time, which can be uncomfortable for them. And I also need to think about any other health concerns that I might have, or caregiving responsibilities, or work-related stress, other things that might be impacting my life. And then when I think about treatments, I want to think about what other medications I might be taking, again, my overall health, what kind of side effects some of these treatments might have, how easy are they to use, and how affordable they are, right? So I need to weigh all these things to think about how a treatment might impact my symptoms and my quality of life. Thinking about relief and whether I want treatment for my symptoms. Not all women decide that they want treatment for their symptoms, and it's perfectly okay either way. I think about, we're very tolerant of women who do and don't want an epidural during childbirth. And I think it should be the same at menopause. You may or may not want something to help you with your symptoms at menopause. All of these symptoms that we talked about can really impact your physical well-being, your emotional well-being. When you don't sleep in particular, it can affect your mood during the day, and it can also impact things like your immune system. And so it's really important to take really good care of yourself during menopause. This is an important time of change, and it's a really good time to be sure that you're eating well and exercising and doing some kind of stress relief. Okay, next slide, Abby. I think we've already talked about this. I do want to say that some of these symptoms can have what we call an additive effect. So I'm having hot flashes and sleep disturbances, but they're going on so long that they seem like it's not just two symptoms, it's like this glob of symptoms. Or they're multiplying their effects on my quality of life. In my studies, women have mostly said that hot flashes disrupt their sleep, mood, and concentration. And you can see how those all go hand in hand, right? Because it's the sleep disruption also affects your mood and your concentration. And there's some research that shows that VMS actually have an impact on your brain. And so some of the concentration difficulties could be related to hormone changes. They could be related to the vasomotor symptoms themselves. I think the other thing to think about impact is that treatments may not fully work for all women. And that can be a really hard place. If you have a friend who has a lot of symptoms and is taking treatments and they don't seem to be working, that's unfortunately not an unusual case. I think sometimes we lose patience for people. We think of them as complainers. But this definitely can happen where treatments can't work. And on the other hand, it can also take multiple attempts to find a treatment that works. People will go through 4 or 5 different treatments before they find one that they're really happy with, that they feel like it works, and they can tolerate side effects. Next slide, Abby. When you're talking to folks about menopause, and I know some of you really advocate for women at menopause, I think these are important points to talk about. When women have these menopause symptoms, they miss work because they're not feeling well, or they try to work when they're not feeling well. And in the work world, that's called higher absenteeism and higher presenteeism. And what that means is there's less productivity. So there's a cost to employers, big businesses, small businesses, with women with menopause symptoms. And so if those businesses don't have appropriate healthcare plans or ways to support women at menopause, it can actually affect their bottom line. So you can advocate at your workplace for some programs or maybe health benefits that encompass medications that might be needed, things like that, based on this sort of economic argument. The other thing is that women at menopause, we know, have more office visits with healthcare providers. And I've mentioned that their sleep problems can affect immune functioning, which can lead to more healthcare visits as well. And so, again, this has a bottom line impact on our businesses around Indiana. So any of you wanting to advocate or push legislation through, I think these are the kind of points you want to emphasize in terms of why programs to help menopausal women are really important. In the UK, the United Kingdom, there are big initiatives to help women at menopause. I would say we're about 10 years behind that here in the US. Okay, next slide, Abby. So we're going to talk for a bit about finding the right healthcare provider. Next slide. And I think it's really important to just talk through a little bit about why do we need a healthcare provider who understands menopause, right? And getting accurate diagnosis is really important. There are some menopause symptoms that can mimic other disease states or conditions. And so it's really important not to assume that you're going through menopause, but actually work with a provider who can actually diagnose menopause and differentiate it from other potential health issues. An example that I'll give you from my own work is that I had a young woman who thought she was having hot flashes. And she was actually found out she was diabetic and was having low blood sugar reactions that were causing her to sweat. And so she got the care she needed for diabetes rather than for menopause. Getting timely treatment is really important. These symptoms can worsen sometimes over the menopause transition. And so it's important to have a provider that understands if you're there in an office wanting treatment now, chances are you're going to want that treatment even more a month or two from now. So getting that early, timely treatment is really important. A provider that provides personalized care is so important, right? We are all so different. Our experiences are so different. Menopause affects each woman differently. And you really want someone who can offer a personalized treatment plan for you. It can also include medications as well as other options that are not medications, and take into account your health history. Comprehensive management of symptoms. Because these can be additive or kind of multiply upon one another, you want to be sure that a provider can address multiple symptoms at once. I had a colleague who went to I believe it was a physician, and they couldn't talk about more than one symptom at a time in the visit. And so my colleague decided to go to another provider because in her mind, those symptoms were all intricately linked and needed to all be treated together. Shared decision-making is when you're involved in making that treatment decision, right? You and your provider together agree on something that's reasonable, that's medically reasonable and makes sense. It's fact-based, evidence-based, and also makes sense for your lifestyle, your preferences, your needs and wants. And then thinking about whole woman care, just understanding the full impact on you, both physically and emotionally. It's a time also where we're aging, right? And so there can be some concerns that happen around aging, and having someone that you can talk with about that is important. As we age, there's additional health issues that come up, right? So is this provider also maybe concerned about your bone density and maybe ordering a bone density scan? Or are they thinking about when was your last mammogram or breast exam? What about a colonoscopy? So really thinking about the whole person. Some of this depends on the type and level of care that you get. Some women will see a primary care provider as well as a menopause specialist. And so that whole woman care might be sort of delegated to the primary care provider rather than to that menopause specialist, but just making sure there's good communication among people is really important too. And this is a long process. So it takes about, we talked about a year with no periods, but women can have symptoms for 8 to 10 years. So this is a long period of time to be working with providers and really have them understand your situation. Okay, next slide. So how can you find a healthcare provider who understands and takes menopause seriously? Menopause.org is the official website of the Menopause Society. It used to be the North American Menopause Society. They're the only credentialing agency in North America that certifies menopause practitioners. So you will find OBGYNs, you will find women's health specialists with credentials, but the menopause certification is only available through the Menopause Society. You can ask your friends, relatives, physicians, nurse practitioners for recommendations. I think online reviews are really great, but I caution you when it's a new provider, sometimes, they don't have a lot of reviews, and 1 or 2 negative reviews can really skew things for them. So, just kind of take that into consideration as you're looking at online reviews, and look at their experience. Are they talking about how they can handle menopause? They see women at menopause regularly. I think an example of the CHEK experience is there is a treatment that's used, it's called a pellet. And they can cause real problems because they increase testosterone levels almost to the point of being like transgender care type doses of testosterone. So really significant changes that women can experience. And when we talk to women, they're being prescribed by people who were former emergency room physicians or nurse practitioners who have now decided to go into menopause care. So that's what I mean about checking experience. What kind of background do they have? What kind of patients have they cared for? What are their credentials? Okay, things to avoid. You may unfortunately have had some experience with some of these. Providers that dismiss your symptoms, saying it's just your age, it's all in your head. Providers who don't seem very informed about menopause, either symptoms, treatment options, just really don't have that information for you. Some providers offer a fairly generic treatment plan. This is the way we do it, and that may not work for you. So a provider that's not willing to engage in personalizing things for you probably isn't a good option. Providers may be unable or unwilling to discuss all treatment options, and by unable, I mean they may not have the knowledge necessary to manage menopause. Limited availability is becoming a huge issue. As providers are, there's been a real change in the marketplace, right? There's a lot more places to go to get menopause care. There is telehealth that you can get across state lines if you don't have providers in your state. And what's happening is those providers are getting kind of inundated with clinic visits. And so, you may find a good provider and then have difficulty getting into that provider in a timely fashion. Poor communication, lack of empathy, people who don't listen, interrupt frequently, fail to explain things clearly, maybe aren't open to shared decision-making. And then people with very negative reviews, consistently negative reviews or testimonials from patients, obviously is something that you would want to avoid there. I think Megan, or Abby, we can take a few questions, Megan or Abby, if there are some.
Yep. The first one we have is, what about women who continue to use IUDs so they don't have a period to track? When should women stop using IUDs?
Yeah, that's a great question. When you have an IUD and you're not having your period, some women with IUDs will begin to be symptomatic with menopause symptoms, and it's really important to talk with your provider about whether you want to leave that IUD in to get some of the hormones, or if you want to have that taken out and begin tracking your periods to really study those. I'm in talking with providers, there's a lot of variability about how those providers are handling IUDs. So I would just really encourage you to talk with your healthcare provider about the best way to handle that. And when you are perimenopausal, you are potentially still ovulating. So you also want to be careful about unintended pregnancies if you don't want to become pregnant in your late 40s or early 50s.
Thank you.
Oh, one more question, Megan.
Yep. And it's along the same lines, similar. But if you don't have periods for other reasons, such as an IUD or a hysterectomy, etc., how do you know when that 12 months is actually over?
Yeah, so the symptoms will be an indication that you're in perimenopause generally, although again, some women don't have symptoms. And then a provider will track your hormone levels for you to help kind of understand where you might be in menopause, and can follow you over a year or two to understand how long that perimenopause period might be lasting, and then into postmenopause when that starts. But it is a little bit harder to figure out that exact menopause day, for sure. All right, let's talk a little bit about how you can get ready for an appointment with a provider. I use the word provider because We have physicians, we have nurse practitioners, we have physician's assistants. We have lots of different people. So I try and say provider to sort of cover all of that. Before your appointment, be sure you have your list of medications, your medical history. Look up when your last mammogram, your last breast exam, or last pelvic exam were. These are all things that a provider is likely to ask you about. And if you're seeing a menopause specialist, they may or may not be within your normal network of care. And then be sure you've written down your last 2 or 3 days that your menstrual period started. List all of your questions and concerns. So just write a big old list and then pick 2 to talk about at the first visit. The most common thing that I hear from providers is that they are overwhelmed during an initial visit by the number of questions that women have. And they spend a lot of time trying to sort out what are the most important things to talk about at a first visit, because they know they can't address them all. And so I would say, pick 2. Symptoms are usually a top concern for women. And if you want to talk about your symptoms or your treatment options, I'm going to encourage you to keep a symptom diary for 7 days or more, where you write down the day or the time of day that you have the symptom, whether it felt mild, moderate, or severe to you, and whether it was disruptive to your life, your mood, your sleep, your work, your concentration. And on the next slide, I think we have an example of one of these. Oh, we will, but this is another way. A really easy way to count hot flashes is put 20 pennies in your left pocket, or nickels or dimes or whatever you have when you start your day in the morning, and just move one to your right pocket every time you have a hot flash. If by noon you have 20 pennies in your right pocket, you can transfer them back the other way, right? But you're basically going to count your change and count how many hot flashes that you've had. At night, sometimes the dog will eat your pennies, so you might not want to leave those out. You can keep something like popsicle sticks on your nightstand. You can get those at any craft store, and just move them from like one side of your nightstand to the other during the night, either when you're waking up because you want to keep track of how many sleep disruptions you have, or when you're waking up sweaty or with a hot flash because you want to count how many vasomotor symptoms you have. It's just an easy way where you're not, especially those of us that wear glasses, right? You're not having to put on your glasses and maybe turn on a light to write something down. Just moving something to the side can be an easy way to count those hot flashes or awakenings. This is the example of the hot flash diary. So I wanted to talk with my provider about my nighttime hot flashes in particular. And so I kept this diary for a week, and this is how many hot flashes I had at night. Each night, I was using the popsicle sticks. So in the morning, I was like, oh, I had 7 last night. They were all severe. There was 5 times I woke up all sweaty. There was this one day on Friday where I don't know if I had 1 or not, but I was kind of sweaty when I woke up in the morning. And then on Saturday, it was like I was just on fire all night long, right? So was that one continuous hot flash? That's what it felt like. Or was it multiple hot flashes? I don't know. But this is my diary that I'm going to show my provider so that my provider can see how many I'm having, how I'm rating them, and like what's happening. So I'm all sweaty and gross when I wake up. My sheets are wet, right? It's hard for me to get back to sleep. This is important for a provider to know. And next slide. This is another example of a diary where you might be having trouble concentrating. That might be your main symptom. And so, the difficult thing here is you forget to keep the diary, right? And so, a calendar reminder on your phone to write things down. But these are the kind of things you might be experiencing, right? Like I'm at work in the afternoon, I couldn't get work done for a deadline because I was having so much trouble focusing. On Wednesday at the end of the workday, I forgot my cat at the vet's and I had to pay an emergency overnight boarding fee. At lunchtime on Friday, I noticed giving this menopause presentation, I kept forgetting words. I got booed by the audience. On Saturday, my family was making fun of me. I couldn't remember anything. I just felt kind of humiliated, right? So this gives your provider a really good snapshot of how often you're having the symptoms. So 4 times this week, it was either moderate to severe, issues with focusing, forgetting, word recall, memory, and it's having an impact on this person's life. So this is really important for your provider to know about. So rather than just saying, I'm having trouble remembering, this kind of level of detail can really help a provider out. Next slide. So during your appointment, you're going to clearly state the top 2 reasons or concerns, questions or concerns that you have. If this is not a telehealth visit and you're in the clinic, you'll of course have kind of the standard things done by a medical assistant, licensed practical nurse, or a registered nurse: height and weight, vital signs, review of your medical history, allergies, reason for your visit. So the reason for your visit is the first time you're going to state those top 2 questions or concerns. I'm here for my symptoms. I'm here to find out if I'm in perimenopause, maybe. And then if it's a standard visit that's done by a nurse practitioner, physician's assistant, or a physician, they should listen to what is the reason for your visit, what are your top 2 questions. They may or may not do a physical examination. I'm finding that many of the providers prefer that first visit to be much more about discussing concerns and issues. And then maybe a discussion of next steps, some additional tests you might need, treatments. So you might have an initial visit and end up going back, say, a month later to talk about what does the lab work say, what does your blood work say, how are your symptoms the same, have they changed at all, before you talk about treatment options. Next slide. So these are just some examples of clearly stating questions or concerns. And I'm putting these up here because they're really short and concise, right? A provider has 7 to 10 minutes to spend with you. So you want to say, you don't want to beat around the bush. You don't want to use a lot of flowery language. You just want to be really matter of fact. I'm here to talk about 2 things: my hot flashes, my memory problems. I have diaries. I came here to talk about 2 things. Should I change my antidepressant to one that's going to help my hot flashes? Should I be taking hormone therapy? I have a hot flash diary. I want to talk about treatment options, even though I have a big family history of breast cancer. I'm here to find out if I'm in menopause and if I can get help for my heart palpitations. So, these are the 2 things, like really quick. This is what I'm here for. And you're going to be developing this relationship over time with the provider, right? And so you want to be sure they have confidence that you know yourself, you know what's going on, you know what you need help with. And they have it gives them some confidence that they can help you, right, with these 2 things, rather than I have 20 things about menopause, I'm completely overwhelmed, I don't even know where to start, right? That can be overwhelming for the provider as well. Okay, next. You may or may not get hormone levels checked, depending on what's going on in your body, how your periods are, that kind of thing. You may or may not get those checked. You should not be disappointed or think that a provider is not doing their job if they don't draw blood. You may or may not get a thyroid checked. You may or may not get other blood work checked. You might get an EKG or other heart tests if you're having palpitations. You might get referred for a sleep study. And there may be other tests a provider might need depending on your specific concerns. I hear a lot from women who say they did not do this after an initial visit, and they give up on that provider. And I would just encourage you to again, have more of a conversation and build that relationship with the new provider. And the next time you go, that might be a top concern. Should I have my hormones checked, or when should I have my hormones checked, rather than assuming a provider didn't do something correctly. Okay, next. These are the treatments for vasomotor symptoms, hot flashes and night sweats. So there's really 3 treatments that are approved by the Food and Drug Administration. And one, of course, is hormone therapy, which can include estrogen or progesterone. That is given in very low doses now, much lower than what was tested in prior research studies that are out there. The newest one on the market is, you've probably seen commercials for it, Veoza. The drug name is fezolinetant. And then paroxetine or Paxil, Brisdel is another common name for those. Paroxetine is it's a type of antidepressant. It's an SSRI, a selective serotonin reuptake inhibitor. So when this is a common question I get from women, I went to see someone about hot flashes and they told me I needed an antidepressant. And the woman gets upset because they think the provider is telling them that they're depressed. And what the provider is trying to convey is that antidepressants actually work for hot flashes. We're not quite sure the mechanism that they work, and they work differently. So if you were to take paroxetine for depression, it takes about 6 weeks to work, and you take a much higher dose. But when we give you a low dose for hot flashes, it works within about a week. So it's working on a different mechanism. It's a lower dose. There is something that it's doing to alleviate the hot flashes. Then there's other medications that have been shown in research to be very effective in treating hot flashes. And those are other SSRI or selective serotonin norepinephrine reuptake inhibitors, the SSNRI antidepressants. Examples of those would be venlafaxine, Effexor, Prozac. That's just a few of them. And then there's gabapentinoids. I think the most common one you might have heard of is Neurontin. There's also oxybutynin, which is, there's some evidence, not as much. That's one that's actually used for bladder issues, incontinence. And that can also, there's some evidence that suggests that helps with hot flashes. And then if you don't want a medication at all, you can take some non-drug options. Cognitive behavioral therapy and clinical hypnosis are treatments that you can either see a mental health provider for those, or there's also programs that you can do on apps on your phone, or with workbooks that are available on Amazon. And they're like programs that you learn about managing your symptoms. The cognitive behavioral therapy seems to help with your perception of the hot flashes. So you might have 10 hot flashes, but they're going to bother you a lot less. And you're going to learn tips and tricks to help you sleep better despite the hot flashes. The clinical hypnosis actually seems to have more of a physiologic effect on the hot flashes, so that will get rid of the hot flashes as well as help treat the severity of them. There's something called a stellate ganglion block, which is it's a nerve block. It's actually an injection that's done like right around this area, your upper chest area. And a physician will put an anesthetic into the stellate ganglion, and that nerve block prevents the flushing and the sense of heat that you feel with the hot flashes. That is still kind of emerging evidence for the stellate ganglion block. It's a little difficult to find providers who will do that. Sometimes you have to go to a pain clinic or an anesthesiologist for that. And there is some evidence that suggests that weight loss might be helpful in treating hot flashes. And so that's being studied a little bit more now that the medications are being used for, which of course I'm blanking on the name for, that are promoting weight loss, the injections. So that's an option. What's that?
Ozempic.
Yes, like Ozempic, right? Yeah. So those are all the research supported evidence, we call it evidence-based treatments for hot flashes. They're all right there. And next slide, Abby. One more, yeah. I just want to say a few words on herb oils. And my few words are, I don't recommend them. In Europe, they're licensed as medical products. In the USA, they're sold as food supplements. So there's a real difference in how they're produced, packaged, made and tested. I hear a lot of women use black cohosh for hot flashes. There is very high quality research that shows it does not help hot flashes. Any benefits that you might be getting are likely to be a placebo effect, and the problem with that is it'll wear off over time, and you're delaying getting treatment, good treatment for symptoms. The other problem with herbals is that even when we've looked at really high quality research on herbals, when they look at what the herbal is, they're commonly mislabeled or contaminated. So meaning that what's in the bottle is a lower concentration than what the label says, or it's contaminated with either other herbals or other ingredients. You may have been reading about lead contamination and things like chocolate and cinnamon. There are heavy metal contamination as well as other kind of contaminants in some of these products. The other one I want to warn you about, so black cohosh, I think, is a waste of your money. I don't encourage you to use that. And St. John's wort can actually be a little bit dangerous if you're taking other medications. It's touted for its ability to improve your mood or reduce depression. But the difficulty with St. John's wort is it disrupts the metabolism about 50% of prescription drugs. So, okay, let's move on, Abby. Let's move on to that role play.
Thank you. Really quick before we go, I want to say we have about 8 minutes left. So we'll start with some of the role plays, and we may go over you. Of course, we understand that many of you will need to leave right at 1, and that is fine. And I will just pause and say, in case we just keep rolling, please look for that evaluation and fill it out. And thank you for being here. And now we will go ahead and jump into these. And Janet, do you want me to read the summary at the front end of this?
No, I think, nope.
Okay.
Nope, that was for us, really.
Okay, cool.
Yeah.
We're going to look at some different, do some role plays and talk over how you can help identify a good provider, a good plan.
So Abby is going to be the physician in this first one here.
Okay. Hi, Mrs. Too Hot. I'm Dr. Smith. It's nice to meet you.
Oh, it's nice to meet you too.
Can you tell me what brought you in today? What questions or concerns you have?
I'm here for 2 reasons. My period stopped 4 months ago and my hot flushes are getting worse. They wake me up at night. I'm really tired during the day. Here's a diary. It shows you how many I had last week. And I think I'm in perimenopause.
Okay, well, I need to know more. You said your last period was 4 months ago. What were they like before they stopped, the month and date that they stopped, and are you using any contraceptives?
Well, they've pretty much been regular. I've never taken birth control, no IUD. I don't even have sex, really. My periods just stopped altogether. My last one was September 20th, 2024. It was like one day they were there as usual, and next month, nothing since.
Okay. I mean, your periods have probably just stopped for good. You're probably in menopause. I wouldn't really worry about it. A lot of women go through the same thing.
Well, you haven't looked at my diary. I'm having a lot of hot flushes at night. I wake up drenched in sweat. One night I felt like I had this continuous, never-ending hot flash. It was awful. And the next day I was a wreck. I'm tired, yawning, falling asleep, reading. Like I'm barely holding it together.
I mean, I'm listening to you. I don't really need to look at your diary because I can hear you. Again, a lot of women have these. It's really nothing to worry about, okay?
But there's got to be something I can do.
Not really. I mean, it's just a natural phase. It'll pass.
Ah, is that what you all are saying? Ah, oh no. Right? Yeah, so we have a dismissive provider here, right? And we have somebody who is just saying this is normal, natural. There's really nothing I can do for you. So they really don't have the background and education to help you. This is probably a situation where you would go find a different provider, right? I would. All right.
Okay, our next one. I'll be the patient and you'll be the provider.
Ooh, excellent. Okay. Hi, Mrs. Jones. It's so great to see you. The last time you talked, you wondered if you were in perimenopause. We talked about your hot flashes. You had some lab results done. I looked at your lab results and it looks like you're in perimenopause. So the hormone changes you're having are likely what's causing your hot flashes. How have your hot flashes been since our last visit?
I mean, I've been managing, but the hot flashes and the sleep issues are still a big problem for me.
No, I'm sorry to hear that. I see the nurse's notes that you attended our menopause education classes. Is that right?
Yeah, that's right. I found them to be really helpful. It was great to learn about all the different treatment options. From what I learned, for me, I kind of want to avoid hormones and medications if possible. I've been reading about clinical hypnosis. I wonder if it might help.
Oh, clinical hypnosis can be, it can be an effective non-drug option. It can be used to manage hot flashes, sleep disturbances. It's a technique that uses guided relaxation, intense concentration, and focused attention. You have this kind of heightened state of awareness, and that can help you manage your symptoms better. Have you ever done anything like that before?
That exactly, but one of the reasons it's interesting is because I used to do a daily meditation and it really seemed to help keep me calm all day. I haven't done it for years. But for the hypnosis, I guess, how does it work exactly?
We usually during the session, a trained therapist guides you into a really deeply relaxed state, and then you use some suggestions that help you manage your symptoms. For example, they might talk with you about or suggest ways to cool down or techniques that might improve your sleep, or they might have you visualize an iceberg. It's safe, it's non-invasive. Research shows it can help improve sleep and hot flashes.
Cool. Is it something, how often would I have to do it? And would I see some benefits right away or how long would that take?
You might start with weekly sessions for a few weeks and then adjust based on your progress. I think the typical is about 6 to 8 sessions. Some women notice improvement right away after just a few sessions, and other women might need 6 or 8 sessions for it to work. So you have to be a little patient and consistent with the practice.
Okay. I can't really think of anything, but are there any risks or side effects I should be aware of?
No, that's a great question. It's generally very safe. The most common side effect is that women feel very relaxed, which is usually a really positive outcome.
Yeah.
But it's really important that you work with a qualified therapist who has some experience in treating these symptoms, or if you use, I have an app I can share with you at the end of the visit too.
Um, if it doesn't work though, like there's still medication options I could try afterwards.
Absolutely, yeah. You
Okay.
could give the clinical hypnosis a try, and if that doesn't work, come back and see me and we can talk about other treatment options for you. Absolutely.
Okay, and so where do I find a qualified hypnotist therapist for this? It
Um,
seems rare.
yeah, our nurses actually have a list for you,
Oh,
and they have a good track record with patients experiencing similar symptoms.
that's awesome. Thank you. I appreciate your support. I'm looking forward to trying it out, and I really, really hope it helps.
Oh, you're welcome. I'm really want to be here to help you through this transition. I'm really glad that you reached out for some help and, you're getting the information you need to help manage your symptoms. I'll have the nurse check in with you in about a month or 6 weeks, see how you're doing. And if you want another visit to talk about a different treatment, or if we want to wait a few months to see you.
So thank you. I will. I'll stay connected. Thank you again.
Great. All right, so there we've got a really knowledgeable provider who provides a lot of answers. Our patient was nice and concise in what they needed, what they wanted. Ahead of time had thought things through, had a treatment option they had identified. This provider even had education classes to refer a person to get some treatment information. So that's really an ideal kind of situation, right? And they did some shared decision making about what the patient thought was best for them, what the provider could do if that didn't work, right? So they have not just an immediate treatment, but okay, what happens if it doesn't work? We'll go on to something else. So that's really an ideal situation. Do we want to go to questions, Abby?
Sure, let's do that.
Okay.
Yeah, we'll go right, we have a minute or two for some questions. So Megan, if you could help with that, that would be amazing. Thank you.
Yep, we have a few questions. The first one is, what about weight gain? I've been eating healthy for over a month and my weight is still the same. Backstory, I am 49 and not having a menstrual for 7 months. Now I am having one.
Oh, yes. So you are likely in perimenopause, it sounds like. You'll be starting your clock all over again after having that one period. And weight gain is common in this period of time. We know that our body kind of stores cortisol during menopause, and that can contribute to some of that weight gain. Think about the weight gain as temporary. And don't get too distressed about it and don't give up on yourself. So keep doing the best you can in terms of eating and exercise. I would say if you can do more weight bearing exercise, weight training, and build that muscle mass up, that can help you lose some weight as well. Very common.
Next question is, if menopausal symptoms begin at 41 and I'm now almost 60, still experiencing many symptoms. Is there an end in sight for having no symptoms?
So the majority of women will have symptoms for 8 to 10 years. Some women have symptoms into their 70s and 80s. I truly hope that you are not one of those folks. I had symptoms for a good 20 years myself. Now, they were much more intense the first 10 years than they were later on. They're less frequent, they're less intense. Every once in a while, I still have a hot flash like 25 years after my hysterectomy. So it can really be individualized, but you may be one of those women who continues to have symptoms for a longer period of time and could still think about treatment options for yourself. So keep that in mind.
Next,
I'm gonna actually skip to the one about the periods are disruptive, really excessive bleeding. That is something that you should see a provider about. And again, I think this is where a diary can be really helpful. How many pads, tampons, menstrual cups are you going through in a 24-hour period of time? How many days are your periods lasting? It's not uncommon with all of that heavy bleeding for women to get a bit anemic during this period of life. And so really important that you have a provider who knows what's going on with you and is helping watch that.
okay, next question is, I have read differing opinions about history of a clot and hormone therapy. One thing I read was that a low dose patch is okay with a history of clot. Also, not all clots are caused by a blood or genetic disorder. What is best practice?
I'm going to refer you to a healthcare provider on that. The low dose patches do have they're better tolerated, much fewer side effects. I would just need to know like your full medical history to really understand your risk with using those patches and in terms of blood clots. So definitely something to talk about with a provider. That specific question could be answered really, really well by a menopause certified provider. Yeah.
Can you talk a little bit more about when labs should be drawn versus treatment determined by symptoms and labs are unnecessary?
Yeah, I'll give you an example when labs or lab work isn't very informative, and that's when women are still having menstrual cycles. And depending on where you are in the cycle can impact those labs. And so sometimes providers will not want to get labs at that moment in time. Whereas if you haven't had a period in 6 or 7 months, we would likely begin to see that declining estradiol levels, rising FSH levels. That can be a little bit more definitive sometimes. So sometimes providers will want to wait based on your menstrual cycle history, whether or not you have an IUD, that can also impact those hormone levels. So it just really depends on what's going on with your own personal medical history.
Thank you. Next question is, should I be worried if I have all other symptoms related to perimenopause, but no hot flashes?
Ah, gosh, I wouldn't be worried. I would be very happy, actually. The funny thing about hot flashes is that there's different patterns as to when they start. And so some women, a lot of women will start them in perimenopause and have them either up to postmenopause or through beyond postmenopause. But there are other women that actually will start having them in postmenopause. So it depends on what your pattern is. Definitely nothing to worry about, something to keep an eye on and notice if you do start having them. But no, nothing to worry about there. And does taking estradiol delay the inevitable? I think this is a great question. And I think part of this is around, if I take hormone therapy, what happens when I stop it? When I stop it, do all of my symptoms come back? And there is a lot of individual variability around that. Not all women will have those symptoms again when they stop hormone therapy.
Thank you. And then it looks like the last question we have is hypnosis typically covered by insurance?
You know, I don't know the answer to that. I'll have to find that out. I'm so sorry that I don't know that.
And that is all the questions oh, one just came through. How concerning are heart palpitations associated with menopause, and how are they treated versus other possible heart conditions?
We don't know the answer to that, about how concerning they are. We don't have a sense of if they lead to other health conditions, down the road. There is some evidence that older women that have palpitations, have increased risk of, mortality. So, the thing about the heart palpitations is they can be caused for different reasons. You can have heart palpitations because you're anemic, because your thyroid isn't functioning well, or because of hormone changes. So again, I think a diary is really important. How often are you having them? What do you feel? Are you having any other symptoms like dizziness, lightheadedness, chest pain? Definitely something to talk with your provider about if you are having any of those kind of symptoms along with the palpitations. Thank you so much.
Thank you. Thank you, everyone, for hanging in. Again, this will be recorded and posted for you to view. Thank you, Megan, for your work helping us put this together. Thank you, Dr. Carpenter. I just am really excited about putting the focus on women as we age and really getting into that work. We hope you'll join us. Our next one in the series is Monday, February 24th from 12 to 12:45, so short, and we'll really get to dig into some of Dr. Carpenter and others' research around hot flashes specifically. Yay! And it's so interesting. I knew nothing about how things varied so much in that regard. So we're excited about that. And we'll keep you on the list for the future webinars in this series. And please, again, fill out the registration. Visit us at htt.org. Visit these resources on your screen right now for more information about menopause. And thank you again for taking this time and joining us.
Thank you, everyone. I really enjoyed it.
Thank you.